Good morning, class. Please confirm that you can hear loud and clear. Yeah, and that this is your third class, isn't it? Which section is it? B. Okay. And I think we have talked about uh, the screening tool, mini cog, isn't it? Okay, so screening for cognitive impairment, starting from there again briefly. Genetic testing for this apolipoprotein epsilon 4 uh, mutation, and remember its presence um, just supports our diagnosis. If absent, does not mean that the person cannot have dementia. And then we have cognitive tests, the mini cog and proper Montreal cognitive assessment that I think I've already shown you. Then, the decision making capacity of the patient need to be assessed as well, because they already have a problem with their uh, memory and some at least one cognitive ability as well. Now, having said all that about uh, dementia, um, how it presents, and having said that delirium coexists with it very commonly. Having talked about a whole range of underlying conditions and deficiencies which can lead on to possible outcome of dementia, right? Having said that, Alzheimer's coexist with it up to 80% of the time. Having said all that, and now knowing quite clearly about the presentation, right? Another thing that has to be mentioned here is that in the presentation of dementia, the memory deficit that we have been talking about, uh, if on its own, if we can comment on it, without saying what type of memory deficit it may be. But this aspect of memory, deterioration, can be referred to as amnestic syndrome or amnesia in general. So then, how is it different from dementia? Thing is, both amnesia and this dementia have a problem with, memory. But when we say long term and short term, it's one thing to say how long or short this problem may last. That's one thing, right? The problem more likely or will last for a long period of time. Dementia, as we have said, is a persistent and progressive problem. So the problem is definitely long term. That's, you know, its persistence. Um, and this, memory deficit, however, as far as we talk about purely amnestic memory issues, that memory problem is in case of amnestic syndromic presentation, or just simply saying amnesia, that is uh, not certain to be lasting for long term or short term. One thing. Number two, in amnesia only, recalling recent events is a problem, right? Recalling events from past history is not an issue, right? um, but along with only amnestic presentation, the patients may have their difficulty in learning new skills. They may have some problems with that, but otherwise, the cognitive um, problems and issues, as we just said, there's at least supposed to be one cognitive problem. That is only a thing with dementia, right? So, in pure amnestic presentation, there can be difficulty in learning new skills, but other skills in terms of mostly, you know, activities or linguistic, uh, skills. But otherwise, memory related problem is related with recalling recent events. And then that it's not certain that it may last or may not last forever. Amnesia, right? But dementia, we know, is a persistent one. And then dementia develops slowly and steadily, right? Depending on the underlying cause. It gets worse over a long period of time, whereas amnesia, not necessarily, right? So there, and then therefore, uh, during dementia, the memory deficit at times may be referred to as amnesia or amnestic episode or amnestic syndrome. So this very tricky stuff, right? So keep that in mind. And so to assess a person's decision making capacity, what do we need to do that for? I mean, we're asking the patient to make their choices about their preferences and values, and what are we going to do with them, or what they want with their issues. And what if they're not even in the capacity of giving the consent or making a decision, right? So what are the things to pay attention to while observing their handling of this situation? So as because they have intellectual, executive and intellectual and decision making, and they have problems with that, possibly can have problems with that, isn't it? So they can have serious decision making challenges. And by doing this screening, we'll be actually screening them, assessing their capacity for giving consent. And for that, there's these five elements to pay attention to. Number one, while having this discussion with them, you're telling them about their condition, and you're giving them options, and you're taking history, all during all that time, are they expressing their choice or not? First thing is expression of choice. Second thing about choice is consistency of choice. So whenever we approach a problem or issue, right, we have a prepared mindset as well. If we are aware of such a topic, let's say, to some extent previously, we hold an opinion about it, right? Or hold a certain degree of understanding about it. So based on that, when in that circumstances that you are now, or patient is now the person in that state and is being talked about. So number one, that they would express their choice. If they express their choice about how to deal with this scenario, what would their preference be? And then their consistency with the choice, right, is important factor. telling us about their having the capacity to make their decisions. Why? Because, as I said, we hold an opinion. It's another thing that, yes, and the reasoning can be there. And that will also be an important factor to look at. That are they actually reasoning and exploring and having a discussion about it or not, right? So, ability to express choice, understanding risks and benefits, and alternative options. Because when you give them those, they will inquire about it, right? They will get involved in this discussion. The comprehension of problem and its consequences, right? So when they discuss about it, you would get an idea that uh, that option that you're giving them, they might be actually thinking, verbally thinking about it, and then while picking up an option or a treatment choice or a course of action, they may themselves think about, oh, then, but this can possibly have so and so issues, and then may bring up that issue with the physicians, doctors, try to ask about it as well. So that means that they have an idea about the consequences as well. Ability to reason, right? And consistency of choice. Now, this another two things. Remember, we said that there can be variability in values and preferences, right? That's not within one session, that is in multiple sessions. When the patient goes back and then comes back, see you next time, then again, they go back and then see you next time. So that's, if they change their mind during that, right, that is totally acceptable. But during a conversation, we are saying if they are choosing something based on certain reasoning and they're sticking to their line of thought and therefore choice, right? So that indicates that they are much capable of actually decision making. Does that make sense? Yeah. So these are those five elements to pay attention to while talking with the patient of, cognition and memory related problems, to assess if they have the capacity actually to make their decision. Then about symptoms or the clinical presentations, how to actually go about that. It's not literally how the patients are going to be presenting, right? So, clinical features and symptom screening, this kind of content in this chapter is not always going to give you just the symptoms and signs and presentation of the patient, right? It will be about what has been found to be happening and how to basically go about finding and looking for symptoms and presentations and screening them, right? So we can gather information obviously about dementia by talking to the patient. Remember, um, we have talked about different types of dementia, and I've shown you a few tables, uh, talking about the features, characteristics. So from when you talk about the characteristics of their problems and details about it, you'll get to have a picture about it. So rate of progression, deficit, and the nature of basically the problems can be assessed by talking with the patient, right? And this is what differentiates one type of dementia from another type of dementia, if you can go back to those tables. In physical examinations, neurologic examination will have to be considered surely, because a lot of the times, up to like 80-90% of the time, there is neurodegenerative disorders underlying taking place. So neurologic, and then it affects cognition as well. So definitely assessment of physical examination of nervous system and neurological examination. Now overall, this will be for mental status, for sensory deficit, and for obviously pre-existing strokes and their effects, on their neurologic capability, Parkinsonism, and peripheral neuropathy. And then I don't know if you guys have actually studied physical examination of nervous system and neurologic aspects to what extent. I did talk about them a little bit in the first semester, but however, and how much I talked about it for the physical examination, which was a lot, if you remember, it was not supposed to be basically the part of that semester to begin with. It was supposed to be the part of physiology subject and the way everything is designed and was designed, right? But I still went through it. So I did talk about a little bit about nervous system examination as well, sensory and whatnot, but not to all. So when we study nervous system, depending on what uh, extent of the content is there, and then how much time we have, we will basically uh, try to talk about it. Yeah, just not the reflexes, but there's a lot of other stuff as well. Senses to be checked, and it's a sensory deficit. Uh, you know, examinations and examinations for effects of stroke and mental status and whatnot. So basically, it will come up, and we'll see. And you already have those physical examination books that I shared with you. Quite a few of them actually. Remember Oxford American Handbook and D. Cowan's and another one. So you can always look in those books. They have illustrative images too. So as I said, when we get to the nervous system, we'll see. So an extensive physical examination is required, and physical examination, therefore, for identification of coexisting other conditions, comorbids, right? Whichever other condition may be coexisting along with this problem of dementia. And what variety of lab tests to be done to be able to evaluate. Remember the causes in mind, right? The list of causes, categories, and varieties of causes that we listed. So complete blood count, electrolytes, calcium, creatinine, glucose, thyroid stimulating hormone, HIV screening, rapid plasma reagent test is basically a type of test for screening of unusual antibodies, and this basically is done for syphilis. Neurosyphilis was one of the underlying causes for dementia. So heavy metal screen test, remember heavy metals were also mentioned in the causes, right? And imaging, as far as is concerned, may not be very much helpful at times, obviously, especially in early stages, right? So, but yeah, CT scans and MRI overall are neuroimagings that we're talking about. So, to rule out and identify subdural hematoma, tumor, previous stroke lesions, hydrocephalus, and excessive fluid accumulations in the brain compartments. And for younger patients who have focal neurological symptoms, meaning HIV, is a viral infection. Remember, infections have an association as well with dementia too. And where um, remember, infection leads on to initiate inflammatory responses, and the consequences of those inflammatory responses can be systemic, right? And then the systemic responses, then there can generally affect, and just like we talked about that uh, fat depositions around the waist, or obesity being associated with dementia, remember? So it has also got to do with inflammation, right? So that's a general fact about chronic long lasting inflammations and conditions which could be causing that. So symptoms which may represent focal lesions in the brain. So imaging to basically uh, find out focal lesions responsible for focal neurological symptoms, seizures, gait abnormalities if they have, right? So in younger patients, the results are much more uh, better represented, especially by doing MRI. So if a patient is younger and have dementia, uh, MRI is a better option. Comparatively, in older patients with classic Alzheimer's presentation, right? Uh, CT scan basically without even a contrast would be sufficient, which means focal lesions would be minute or small size lesions, whereas Alzheimer's disease, because generally globally affects the brain, so there will be quite a lot of lesions, so easily identifiable with CT scan only without contrast even, whereas focal small lesions better identifiable with MRIs, right? And young and old preferences also mentioned. This table also helps you kind of differentiate between Alzheimer's disease and dementia. Remember, vascular dementia, and that they coexist up to 80% of the times. Onset gradual, and here vascular dementia may be sudden. Otherwise, vascular stroke obviously develops suddenly. So vascular dementia may develop sudden. Otherwise, dementia is gradual on developing. So differences, you can look at it, and basically there is this Hachinsky ischemic score. I think I have it here. Do I? No. Why not? I think I downloaded it. No. So there's a few things I noticed that I downloaded but are not present in this folder, so I'll have to re-download them. Go away. So anyways, it's then again a tool basically to help us evaluate. uh, it's a ischemic score, isn't it? Right? So vascular events causing ischemia in the brain and its consequences. So the score greater than 7, uh, if you had to have, let's say, a patient and you're suspecting either Alzheimer's or dementia, in that case, when you assess the patient on this score and they score more than 7, they have vascular dementia. If they score less than 4, they may not have vascular dementia. That's what it means. Then more likely it's Alzheimer's, right? And then obviously it's vascular, so infarctions, and in Alzheimer's, and there's going to be hippocampal shrinkage, and otherwise whatever findings of Alzheimer's can be. But memory related hippocampal atrophy would be identifiable. And differential diagnosis for dementia, uh, you have to, I've already mentioned it before as well, you have to keep it in mind that with aging, everything slows down. It's a downward trend for every part of, activity, functionality, sensory capability as well. So it's common for elderlies to find it difficult to take some time to recall stuff. That is quite normal to an extent. So expect that. And as I said, they have usual slow rate of processing. Now for this point, which has appeared now, is why I mentioned amnesia as well today and tried to help you. There always, you know, someone who does that. So, yeah, for this point, I mentioned amnesia as well today. Mild amnestic in this picture of dementia means mild memory problem, right? Plus mild cognitive impairment. That is what it means, basically, right? And with these mild level of effects, the patients can still retain their normal function. So mild dementia is not that much disabling. And with just mild dementia features, it's not necessary that everyone will lead on to become having full and significant or moderate to severe varieties of dementia. Not necessarily, right? But we have said it's persistent and progressive, so mostly, yeah, it does progress. So 5 to 20% of the times it does progress to an extent that it's not just mild memory related problem, but then cognitive impairment is added to it, and then it can be properly said to be converted to dementia, right? Hope that made sense. So these, you know, I've mentioned previously as well, for old individuals who have their cognitive ability intact, so there's no problem with their cognition, but have a vision or hearing severely impaired for whatever reason. For such an old, because old age person concerned, weak, fragile, and whatnot, remember. So, for such an old person who does not have any problem with their cognitive ability, but has severely hearing or vision senses to be impaired, it's quite easy for them to become confused, and therefore, an confused elderly, can be falsely diagnosed for that reason or labeled as, dementia patient. So you have to screen yourself for that, that you're not doing that. All right. Delirium, I've already talked about it, what that is. It's otherwise um, lack of attention and concentration, leading on to or stemming out confusion, right? And in this confused state, the patient obviously would have difficulty in recalling stuff as well. What, where, when, confusion is there, so they're finding it difficult to make sense of things. Yeah, perception has a problem. So, but it's acute onset and then it will go away if it's delirium, right? It has fluctuating course, and majorly an attention and concentration related issue momentarily, as opposed to the memory issue, which this dementia has. But delirium coexists with dementia as well, so there's a lot of overlaps. So they do coexist. Extent of memory and attention impairment for both is not accessible. See, when delirium is taking place, at that time memory impairment may also be there along with attention and uh, you know confused state of mind. So until and unless this confused state subsides, the episode is over. We cannot begin to actually assess the memory impairment, because dementia usually has memory issue, but delirium acutely may lead on to have a memory related issue. That's what basically is causing confusion. They may not mm, be able to recall everything at that time. So when that acute episode of confusion is over, only then we can see if there is and to what extent a memory related problem, right? Now, what are the drugs that have been, now this is the stuff that I have been mentioning earlier. that has been found through research, historical data, that so and so drugs have been associated with, more strongly, commonly associated with dementia and delirium kind of effects in the patient, affecting the cognitive ability as well. Right now, it's one thing that you may have studied in the side effects and you know whatnot of the drugs, and it's another thing the lists that you get here, because among all those drugs that you may have studied may have a side effect of affecting cognitive capability or causing delirium, right? Among those drugs, which of the ones have been found to be most commonly actually leading on to cause this stuff, they are the ones which are going to be mentioned. And similarly for treatment as well, you may have studied elsewhere while studying drugs as well, for example, that they're used for so and most commonly and the treatment of choice for so and so. In this age group, things may have been found to be differently based on historical data. So what is we mentioned here is going to be based on actual evidence, what has been found to be a more of a fact in this age group, what has found to be more of a better treatment option, for example, in this age group. So the drugs which have been observed to affect on cognitive ability and cause delirium: anticholinergics, hypnotics, neuroleptics, opioids, NSAIDs, antihistamines, corticosteroids, and antihistamines of both H1 and H2 antagonist types. This is the list of drugs that when you ask the patient about their drug history, if they're on them, you can suspect that it could be one of these drugs. Obviously, anyone who is on drugs won't be on all of these, obviously. So, whichever they are on, consider, you know, uh, later on you'll see in management discontinuing, and then maybe if required to necessarily still take it. Um, dose adjustments or finding a better alternative. But these are the ones to be kept in mind, which can be the culprits. So now, how do we treat for the cognitive variety of impairments that we say can take place? If we are talking about geriatrics, I mean, we are in that kind of mindset that it's a country and society and system where a lot of other stuff is available to support as well. So make use of the community services available. There's so many different support groups, societies, and NGOs, non-governmental organizations, charities, right? So they are working in communities in those countries and systems for helping such individuals. And you know, there's so much stuff. So online information is also available, and there's a lot of help and information available to be used. So make sure that they are informed, because in hospitals, when you go to see a doctor in these countries, they actually have all these informations available in forms of printed pamphlets and leaflets and cards right in their offices. So they actually give you handouts and contact information and what the services are that so and so community service or another organization will provide them, right? So all of that is available in their offices, online, on the hospital or practices or health systems websites as well. So they provide such a are supposed to be basically providing this information to the patients, right? So do that. Caregiver counseling education are three categories of services, let's say. So information, education, counseling, which means there would be therapists out in the community available as well, paying focally more attention to these kind of issues and providing service. Caregivers for the patients who would be dependent on other than need carers. So services and companies and whatnot, and care homes to contact for caregivers. And if those are timely utilized, and the patient may not be required to early may not be required to be put into care homes, right? So it can delay that, and delaying as much that can be delayed, the longer the life expectancy of the patient as well. Then, for treatment of cognitive impairment, we have these acetylcholinesterase inhibitors, including donepezil, glantamine, and rivastigmine, right? So, for any drug as treatment, which we may mention, and there would be an information about a trial, means that uh, when started a drug, right? Are you guys there? Okay. When started using a drug as a treatment option, right, in this age group, when a trial has been mentioned, means obviously dosages will be mentioned as well, that the patient would start to take the drug, and the maximum tolerable dose once achieved will be held on to by the patient. Right? And then there would be a time frame that we'll mention, a minimum time frame, right, for each specific drug, that sometimes we'll say that a minimum trial for that time is required to be done before assessing the patient for the effects of the drug, right? It's one thing that you take a drug, for example, even an antihypertensive drug, and then the effects are oral. For oral drugs, let's say the effects are within half hour to like a couple of hours, but it does not mean that's the extent of effect that this drug will have. The full extent of the effect that the drug may achieve could be up till after a few weeks as well. So, at least a certain length of time of trial should be given to variety of different drugs. So the time frame of trial means that it should be given sufficient time to get to its maximum potential effect. So a trial for acetylcholinesterase inhibitors is recommended in mild to moderate Alzheimer's patients, right? Which means they're towards more prominent presentations and signs and symptoms to be present in these patients, right? So, um, however, by using these drugs, there might be some improvements in the cognitive impairment, but it has not shown to be helping in delaying any form of institutionalization here. So admissions or care home placements won't be delayed by treating for cognitive impairment with these drugs, right? And the level of, just like we said, mild to moderate Alzheimer patients, so moderate to severe cognitive impairment is the level of impairment that should be considered to be treated with drug interventions, right? So don't use the drugs right away for mild form of cognitive impairment. Remember, which can't even be identified by using or assessing the basic and instrumental activities. The type that we are saying may be affecting the advanced activities. So that means they are coming to a point. So they were very, very mild ones. So when they become, sorry, I said otherwise, when they become moderate to severe, they'll be affecting basically the even basic activities of life, right? So drugs to be used when they have become that much severe, and um, starting with a low dose, gradually increasing to the maximum tolerable dose. That is basically for every drug pretty much. And 2 months is the trial period, right? So a trial for at least 2 months for the highest tolerated dose. Now the dosages. I won't require you to remember the dosages, remember, but by this final semester is pretty much the time when if you are remembering something, best is to remember the dose as well. And the thing is that it's not going to be possible to remember the dose until and unless you start using that drug actually, in practice, right, and prescribing it repeatedly. Only then you get to retain that information. So bear that in mind, that it's not necessary that you'll be able to remember all the drugs anyways, their dosages, right? So donepezil 5 milligram once. And now this reminds me that I have already downloaded a couple of images for you guys to help you. If you did, work on your own and explored the initial chapters of medicine with the information of how to write prescriptions, and then these are the abbreviations used in prescriptions, right? So OD, BID, TID, QID, QHS, Q4H, STAT. What does all that mean, right? So I've included these two images, and these need to be updated. Where is it? Okay, yeah. So even a longer list of abbreviations that are used uh, in prescriptions. TSP, for example, teaspoon, and TBSP, tablespoon, right? Tablet, syrup, suspension, suppository, right? So these are all variety of different pieces of information that are required to be included in, administration, routes of administration, frequency of administration, what form of the drug do you want, because different drugs come in different forms: injectables, liquid, drinkable forms, syrup, suspensions, and then obviously, in powdered forms as well. So there's a lot of stuff that you have to include at times for prescription as well. So I've included that and will be uploaded to the folders. The document is almost ready, don't worry. And today, definitely, you'll be getting these. All right. So, donepezil. Then you have glantamine and rivastigmine. The dosage is mentioned here as well. And obviously, for any drug, if there's any excessive side effects taking place, or the drug does not seem to improve the cognitive symptoms, or this one reason, the patient just can't afford it, right? uh, you'll have to discontinue them. Simple as it is. Then you have NMDAR antagonists, right? And methyl D aspartate receptor antagonists, memantine, right? So uh, advanced disease patients are the ones that should be considered for this. 5 milligram once a day to maximum 10 milligram twice a day dosage, right? And at times, they may be this memantine may be prescribed along with one of acetylcholinesterase inhibitors, uh, but uh, research has not come up with any significant benefit of that. But in practice, you see these being tried together, right? Is there any extra benefit that will come out of it? Unlikely, but can you try them together? Possibly, right? So, otherwise, now talking about behavioral problems, one was cognitive problem. Remember, these people who have now cognitive issue, memory related issue, and confusion related issue can have behavior problems as well now. So the behavioral problems are best to be um, treated with this non-drug approaches or non-pharmacological approaches, which basically then are a variety of different types of interventions and therapies and counselings and activities that will have to be done. And then what is most useful, they are the ones most useful, right? So number one, it needs to be assured that the behavioral problem that they have is recognized what sort of issue it is, right? um, and know that issue that you have identified is not basically as a result of an underlying thing that you can treat, for example, or you can alleviate, like for example urinary tract obstruction simply in elderlies can cause distress and confusion and lead on to behavioral issue. Remember, these are elderlies which may be only lying on the bed all the time, right? So they can definitely be agitated, unhappy, angry, and whatnot. So if you started to see them acting in a certain, you know, a way that you think is a behavior problem now, um, do consider that it may not just be a behavioral issue stemming out of their cognitive and memory related problem. It could be simply that they're suffering from pain for whatever reason, because maybe they are bedridden and they could even develop bed sores, and that's a whole topic as well, right? Or it could be urinary tract obstruction, or maybe there it's an episode of delirium. So it may not actually. So for an episode of delirium, you cannot do any behavior therapy. They are confused, they are disoriented, and they will be the way they will be at that time, right? So their behavior afterwards is what we're talking about. If that on routine in general, without delirium, without any other issue, right? Yes, they may have that memory and cognitive related problem, but their behaviors, that have been modified because of enduring all this. That is what we need to. So fecal impaction is another thing that can lead on to a misbehaving patient as well. What is fecal impaction? Well, it's kind of something quite similar to uh, what we say is constipation. So, not in constipation, there's no, ability to defecate, right? But in fecal impaction, it is the feces who basically get impacted, hardened, dried, uh, you know, to varying extents within the rectal area, let's say, towards the end of the large intestine, and therefore, in part, is causing difficulty in defecation, maybe causing that pain as well, maybe causing constipation to an extent as well. But it is hardened and it won't come out itself, and it would have attained a certain shape and size as well. So it requires at times, manual help in removing it as well. So that could be a problem. Elderly, right? Um, Important to document, record before they throw a behavior, right? An episode of their acting out. Document what happens before it. Are there any triggers? Is there something that is upsetting them? And then consequences of that behavior. So when they actually have that behavior issue, uh, afterwards, what happens? Does it resolve completely? Do they become pleasant? Are they, or they remain that way, right? So before and after events should also be recorded. And the best approach for behavior related issues in these elderlies, especially for the ones who are living in care homes and even in house and being dependent on others, is whoever is taking care of them, see if they can actually just tolerate it. right? um, Let me tell you one thing. For children as well, when children in their early stages of growing are learning about themselves and their environment, and they realize that they have a personality and they have opinions and they have they can make others, their parents for example, or their family members around them, agree with their wishes. And when they realize this stuff, they start acting out as well, right? So they also start misbehaving then. The point is, the best course of action, even at that time, is not to give in to their behavior, but to tolerate it and be still kind and gentle to them. And you know what happens? It just fades off slowly and steadily. The child realizes that it's not working. So the best case scenario that has been basically, to work the most among everything is this: just to tolerate it for the caregivers. And it's not easy, and it's not very much practical, and it's not nice to ask caregivers to do that as well. But the thing is, they are in this field of work, right? They're trained for that, and they should be, as much as possible to do it. Caregivers should use simple language, not to cause irritation and confusion, and requiring to trying and understand a lot what the caregiver is saying, so that, and breaking down activities into simple components. For example, instead of saying, "Oh, Mr. So and so, we need to take you to the radiology department so that the consultant so and so can actually have a look at your, let's say, bladder, to see if you," just tell them, simplified forms, that I need to get you off your beds. We can pay a visit to a doctor. And that's good enough information broken down into pieces. And while you're taking them into some place otherwise, I mean within a setting of a hospital, then they may ask you about it, or you could later on also inform them about where are you actually taking them. So doctors are not usually doing this, but this is advice for caregivers, or helpers otherwise in the hospital setting as well, as we call them. So these are the most important things to avoid or improve behavioral problems in these patients. Now, as we just said, non-drug approaches uh, otherwise are to put a day in routine, right? And so that they know what happens every day, right? It puts them at ease. There should be a certain, which means create a schedule for their activities, one thing. And otherwise, if they are already on drugs, for especially mood alterations, or sedations, or let's say antipsychotics, antidepressant and stuff like that, discontinue them, as many as you can, right? If it's possible, completely discontinue them and then see what happens. Maybe it could be one of those drugs which could be causing issues. And if the patients have a problem with their sensations, correct that, right? Whichever variety of them. So it could, mostly it is hearing and vision, right? So yeah, so whichever drug, as we said, I mean, one thing that it should not be excessively taken, and secondly, if the patient is on drugs, if it's not as a crucial drug as, for example, for hyperglycemia or otherwise hypertension, discontinue it for a few days and see what happens, right? And otherwise, pharmacological approach, the point, the most important, if the non-drug approaches, which were behavioral and up till here, these strategies altogether have not worked at all, expect that the drugs will also not work to fix their behavior, right? So treatment options including drugs only for the patients, who basically, have such a behavioral issue that they're posing danger to themselves or to others, and they're acting out and whatnot. So, despite that, research and historical data has not had any evidence for the efficacy or effect on the behavior of these patients. Still, we only have antipsychotics as an option, right? So, usual ones as an option are, in this category, a very common one is haloperidol, but that's not a preferred drug in this age category, right? So the more safer ones are the ones which are going to be considered, which includes these ones: risperidone, olanzapine, quetiapine, aripiprazole, right? And well, it's not that you simply cannot choose haloperidol. You'll see its dosage will be also mentioned later on. But the point is, it's not a preferred antipsychotic here, right? So the another point that although these are the safer ones, still these safer ones are the comparatively unsafer, let's say haloperidol. When chosen, know that there is a risk factor for blood vessels or cardiovascular system of the patient with these drugs, so they should be used with caution. And adverse effects therefore compared to placebo has been there for them too. So there's these side effects to be considered: stroke, weight gain, hyperglycemia, and diabetes as well. And that these safer options are a bit more expensive than haloperidol too, which we are not preferring in this age group. But then again, affordability is also a thing. So we have this typical and atypical comparison. I've already made it. Typical antipsychotic is haloperidol. The atypical ones are the ones, right, which are the safer options. So in that comparison, they both are going to be have been found to be increasing the risk of mortality and cerebrovascular events or cardiovascular events. Compared to placebo means something that in a study was not even a drug. So a group was given nothing, maybe but they didn't know, right? Another group was given these typicals or even atypical drugs. So let's say two other groups were there. One was given typical, another was given atypical, and the risks basically for mortality and these complications were observed in basically these drugs as compared to the placebo. Right, and the dosages. If haloperidol have to be given, at most 2 milligram per day, risperidone that much, and citalopram that much. Yeah, point to be noted that this one has arrhythmias as complication, especially for dosages more than 20 milligram. It may have a dosage up to 60 milligram above as well, but for ages above 60, which this geriatric age group is, uh, dosages more than 20 is not recommended because it is very strongly associated with arrhythmias. Okay, so although you have possible dosage of citalopram to be much more than 20, right, like three times more than that is also given in usually other age groups, but in these geriatric ones, not safer to give or consider more than 20. Now, for driving, remember I've already made a comment about that. You assess the degree of effect of dementia on the patients, and you recommend the patients to stop it as well. So, especially for moderate to severely affected patients, you should advise them to stop driving, right? But a lot of patients with dementia keep on driving, and obviously some less, some more, but they are at risk to the population around them, right? So recommend to stop driving, and then we can basically have clinical dementia rating scale as well. Then again, it's another tool to assess and rate dementia, based on which you can actually advise the patient to stop or not to stop driving. But it's best for dementia patients to stop driving in general. It depends what the patient does, right? You cannot take their life away from them, but it's a tough choice. Now, this is something to enlighten your decision about driving as well. That patients who have mild or very mild dementia with very initial stages, 88 for very mild and 69% of mild dementia patients can pass the driving tests in those countries, which is very tough. Which means, in the initial stages of dementia, it's quite okay for them to be driving. But you never know when the dementia would become from mild to moderate. So for that reason, there is uncertainty. Let's stop here and have a break, and then this topic is finishing basically with the financial planning aspect of stuff. 10 minutes break, please. Alright, guys, I'm back. Please confirm that you can hear me clearly, loud enough. Yeah. Okay, so the next bit about dementia is the um you know important. I mean, if the doctor, I don't get last sentence meaning about percentages. Well, it's something for you to look at and realize that I mean, how capable a person can still be, uh, you know, to do drive. So, how capable a person can be to drive while being affected with dementia. But what degree of dementia are we talking about? Very mild to mild, right? Which means it's a very initial stages, and uh, it would be those advanced activities in these patients who might have been affected, right? So they are very much functional, very much capable even for driving. So that in very mild, which is the least form of presentation of um, this dementia, 88% of very mild dementia patients can still pass driving test. 69% of mild dementia, which is one step ahead of very mild, right? Dementia patient, 69% can still pass driving test, which means the initial two stages for dementia do not affect a person as much to prevent them from driving. Let's say that, because 88 to 69%, if you look at the driving test, that would be their passing score. So I would say they're as capable of driving as anyone, right? So that's what it means, right? But the problem is that you can never say when their condition may go from mild to moderate. There's no cutoff point. There's It just happens sometime, right? So for that reason, the risk is there. It may not happen for years, it may not happen for months, it may happen the next day, right? That their classification of dementia would need to be updated, right? You never know that. So the risk is there. That's the issue. So for that reason, advice should be if they can avoid. Let's say their bread and butter depends on their earning and life and well-being, affordability depends on driving. Let's say they're a taxi driver, they're Uber driver, and you tell them stop driving. What the hell are they going to do? It's better than just for them to die, right? So you have to keep that in mind, right? But if it is practically possible for them to consider stop driving, better or best is that they do stop driving. Now similarly, um, such a patient who has come to see a doctor, right, or a doctor is caring for a patient and has recognized that they have started to now be affected uh, with very mild to mild dementia. Now this is the time when they still have the capacity to make their decisions and think about it, and you know allocate, dedicate, designate funds for different purposes and activities, or their expenses that would be coming, for example. So this means that they can do financial planning while they still have the decision making capacity, right? So some people don't have any money, so it's not none of their concern. Some people have a lot of money. Some people have a lot of money and they have plans for it. That so and so part of my money will go to this organization, and my those so many businesses, I need to write them off to my son only, or the daughter only, and not the son, or I need to give it only to my wife, or I'm going to give everything to charity. You never know, right? The point is that it's you who needs to bring it to their attention and recommend that this is the time that they should do their or otherwise, let's say there's an elderly who has like maybe $200,000, $300,000 in their bank, and they're planning for a a life ahead and whatnot of buying a yacht, for example, or a boat and going all around the world, and suddenly the diagnosis of dementia come over, and the doctor tells them, if you do all that, you may not be left with any funds for your care that you may need in coming months to years. You never know, right? So as I said, this cost of living in these care houses exponential if they want whatever level of care they want, right? It could start from like 20, 30, $40,000 onwards, depending on how they want to be lived. And then not all dependents or next of kin, even if they're inheriting millions or billions out of their parents, for example, would likely do what is supposed to be done, take care of them, right? Putting them in the best care facility is what they express their care as. But what if they don't? So informing your patient about all this, that the possible expenses could be coming for you and they could be huge. Obviously you make that looking at the patient outlook as well. Otherwise, it's useless to recommend such a thing. So advanced financial planning extremely important. And in this, giving a power of attorney for that matter. Obviously, not everybody is poor. So money matters are a huge thing. And if you don't advise about that, you put your patient into a great issue problem then. What if legal matters arise and they're told that now you don't even have capacity to make decisions, so tata bye bye to all your wealth, and you can't even decide what to do with it. So advise patients and families for advanced care planning, right? Advise patients and families for advanced financial planning, care planning for care, and financial planning for money matters, inheritances, investments, for example, right? Or then again, placement in care homes. Patients should complete a durable power of attorney for finance matters. Who are they going to give the authority to? For example, handing over a business to a board, to another chief executive, or whatever, if they own a company. No gold standard, otherwise, tests are available to say when the patient may lose financial capacity. That is the issue. You never know when, right? It's going to happen. History of missing funds, missed repeated bill payments are what make things. They are the red flags, as we have talked about previously as well. Unusual repeated purchases that the patient cannot recall. Overdrawn bank accounts. I've already talked about that as well. Increased risk of financial abuse and fraud is also there for these patients. Mentioned that too. These are the targets for spammers, hackers, scammers, and basically even the people walking on the street as well. These elderlies of such sort can easily be tricked. uh, Elderlies generally can also be easily tricked sometimes, right? So they are even more vulnerable for that kind of stuff. Life expectancy for anyone after Alzheimer's diagnosis ranges from 3 to 15 years, and obviously they are the ones who 80% of the times basically, or basically with Alzheimer's dementia coexist. With dementia, 80% of the times Alzheimer's coexists, and with all cases of Alzheimer's, I think dementia would be there. Dementia with Lewy bodies may have comparatively more rapid decline in functionality of the patients. Just a fact that has been observed. And when to refer these patients now to neurologists or psychologists, right? That when an important thing for visiting patients to your OPD as well as in hospitalized environment or even in care homes. When to visit, refer the patient to neurologist or psychologist. Number one, if you want neuropsychological or neurological evaluation, an expert opinion over that, then you can refer it to them. Or when you want to distinguish between dementia and depression, and you cannot do it on your own, and you think then again expert opinion is required, then you can refer to them. Or when you need to be certain before starting a certain medication, let's say, and you want help in diagnosis or expert opinion about it, then you can. And ideally, if it's come to that point, best to take, I mean, in a hospital setting, it's always best to get expert opinion, right? And it does not take much of an in a OPD setting or a clinic kind of a setting, it's a bit difficult. Levy bodies are found on basically histological sampling, and for that matter, the thing is that it's with sampling of the neurological tissue, and basically we have characterized Lewy body dementia to present in certain ways if you look at the previous tables as well. So that's something that by looking at the characteristic of the disease progression, onset, features, and whatnot, we can suspect it could be Lewy body dementia. Confirmation for that only can be happening, I think, by looking at Lewy bodies under a microscope, and for that we need a neurological sample from the brain tissue, and I don't think that is going to be done only after that. So post-mortem probably, right? So to diagnose highly under educated individuals. So if you see a patient that simply does not get your point very easily because they are illiterate, and just very simple, right? And things don't make much sense. So, and you're finding as a general physician, let's say you're finding a difficulty in dealing with them and getting through to them. So you need expert to actually handle such a case, right? So maybe they would have some extra training to handle such situations. So to diagnose highly undereducated individuals, you can refer them to psychologists and neurologists, or whichever you may find suitable. And next topic is depression, right? You may also have studied this before as well. So 2% of adults age 55 and above have major depressive disorders. The main important significant form of its presentation. 14% of elderlies with history of loss of life, of relative, of partner, with the history of disease, chronic illnesses, and life changes, environment, otherwise just chemically and let's say physiologically sick person, which means they have a condition like they are patient of hypertension, they're patient of diabetes, and then maybe there are some other complications of diabetes affecting their eyesight and whatnot, and they need help, physical help in their daily life activities, and have been moved to a care home. Can they get depressed? Very much likely, isn't it? So life changes, that there cannot be a life change as big as this one. Now there's some elderlies who actually become extremely happy after moving to care homes. Why? Because I mean, it's good I would say it's good for their self-esteem. uh, Depending and bothering and being a burden on your loved ones, and keeping them from their daily life activities and bothering them every now and then is not something that a caring elderly or a parent or a grandparent would want for their loved ones, right? So some elderlies who are glad and happy to move to care homes are happy and glad for that reason. The other ones mostly then, who are not going to be happy and can very well be depressed after such a life change of moving to a care home, are out of their love and care and companionship of their family members, right? They've spent a whole life in that environment. Or if they were living alone in a house, that is a lot of the elderlies in Western society, they live alone. As long as both husband and wife are alive, perfectly fine. But once they're, one of the spouse, that's a loss, right? One of the spouses, no more, then it's a life of kind of, you know empty life. So life changes, that's what I'm emphasizing on, right, can lead 14% of such lead on to have depression symptoms, right? And it's extremely common in hospitalized and, as I said, institutionalized elderlies. Let it be in the care homes. Older single men have highest rate of suicide. Um, I would say because men depend a lot on women for everyday life. Love, care, friendship, companionship aside, men are dependent on their spouses, let's say, for daily life activities, for cooking, for a lot of stuff. So if men in those ages are left alone and don't have a companion, it becomes even um, you know even more of a depressing state. And dependability also suddenly stems out. If a female is left alone in such a age group and is living alone, she can still do basic stuff, cook and eat and what. For males, I mean, that would be one of the major issues that they have to then learn to deal with, isn't it? And then other things, as I said, aside, more likely to report these individuals are more likely to report changes other than the mood changes, right? Whereas the mood changes basically are the most crucial ones for diagnosis in case of depression. So that may not be reported themselves by these elderly. So it's important to inquire about them. And you'll see there's a few questions that we can simply ask. And you would have actually come across them likely when studying psychiatry probably. So somatic complaints and psychotic features that the patient is actually experiencing, that can come with the depression and the stress of it, may be talked about. But otherwise, mood alterations and instability of mood may not be reported. So you have to inquire. Depression can be the early symptom of dementia as well. Remember, we mentioned dementia and depression coexist a lot of the time. So bear that in mind, that if somebody seems to be a patient suffering from depression, could be because of dementia. And if depression plus other coexisting conditions that normally affect the patients in this age group are present, can lead on to longer hospital stays and are noted through historical data to have worst outcome for these elderly. So if depression happens, if other comorbids are there, if dementia is there, it's bad prognosis. Why do you need to know? Basically, foreseeable problems and trying to counter the harm, and realize how important it is to counter these problems as much as you can, right? You realize as a physician and make attendants realize, make caregivers realize, and advise the patients as well as much as you can, right? So being a doctor is not always just about prescribing, and that is what we have become mostly these days. They say, when a doctor looks at the patient with a smile, half of the illness is gone that way, simply. So in part, this is a lot of the time what you're doing here, especially in this age group as well. Two screen questions are there, which have been found to be extremely effective in this age group above 65 years of age to screen for depression. First of them, have you felt depressed, hopeless, otherwise, in past 2 weeks? Right? And the second question, have you felt little interest or pleasure in doing things? Remember, depressed, one of the extremely important symptom, let's say, or sign of depression is unwillingness to get out of bed, isn't it? So, which means the person just does not have anything um, worthy enough to wake up for and go out for and to deal with, and that's not healthy. That can be a huge sign of depressed state of mind, right? So these two questions screen depression very effectively in this age group. Remember, this age group activities to begin with, daily life activities to begin with, are very limited, and then in that, if you ask these two things, they're very effective. Right. So if they've answered positively, then if the answer is no, 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 for both of these two, it's okay then. But if answer to these two is positive, then you have this. I still have to download this scale as well. Geriatric depression scale, on which then you'll assess the patient. Simply, you've seen a few scales, you know there would be a few assessment points in that one, and then you'll be pointing, scoring those patients, and then towards the end there will be a score. Higher than that and lower than that will tell you the basically risk factor for depression, if the person should be considered as depressed or not, right? So geriatric depression scale needs to be downloaded and shared with you guys. Right. So another important point is elderly, because of many other reasons, out of habit as well. Otherwise, could be actually alcoholics. So ask about how much alcohol, and then you know how to assess for alcohol. And for medications as well, which medications are they on? Because medicines can also be associated with depression. Benzodiazepines and corticosteroids strongly associated with it. How to treat these patients? Basically, psychosocial interventions are the most important ones. Otherwise, antidepressants are also there. We'll be talking about them briefly as well. So, make them more active, make them more socialized. So, promote socialization. Right? Counseling by a psychiatric intervention. So, refer to a psychologist maybe or psychiatrist, whoever, you know. So, what is the difference basically in psychologists and psychiatrists? One can, obviously, use pharmacological interventions as well, and the other mostly depends on, uh, theoretical or otherwise behavioral approaches. One is a doctor, the other one basically could be a doctor, but PhD doctor, not the MBBS medical doctor. So, different type of these approaches. You guys there? What's the time? 12:45. All right. So, cognitive behavioral therapy, as someone mentioned as well before, and if they do use alcohol, reducing the alcohol intake for otherwise general health as well as for depression as well. Antidepressants and all these approaches basically are also there. Socializing, weaning off addictions, whichever type of addiction, smoking, alcohol, or any other drugs that they may be on. And the drug choices are going to be based on the coexisting conditions and the depression degree of presentation. Then we have these um, SSRIs, which have been, um, you know, um, considered to be the first line of agents and have been shown to be tolerated well in the age group of geriatrics. You have mirtazapine, uh, commonly used, and it's used in case of these conditions: anorexia, insomnia, and weight loss. Right? Then you have duloxetine for patients with neuropathic pain. You know, patients in elderly age. Yes, you have listed it here, right? So, people with geriatric age group have multiple problems. I mean, just having a chronic illness, my, you know, when we were talking about chronic diseases, likely chronic inflammation even as well, it can lead on to, be a great toll on the mind as well. So, any illness that has been causing pain chronically can also be stemming out to become depression as well, right? So, neuropathic pain is a pain that is not very easily, most of the times, treatable or manageable. So, duloxetine in that case, and trial periods has to be for longer time, 8 weeks even. So, if somebody was suffering from depression and then you started medication and then the episode of depression is over, right? continue medication trial period for 8 weeks. That is the recommendation, right? And then, if required, right, if the drugs that you've chosen so far are not as effective and you think you need, some supplementation, we call it augmentation therapy, adding some other drug to the already chosen one. So in that case, lithium methylphenidate and aripiprazole are the ones that can be added to the ones chosen, right? And depending on what kind of problem was underlying and leading on to depression, so these can be added. One of them can be added basically. And then otherwise we have electroconvulsive therapy as well. In patients, especially who have severe depression or are catatonic, which means obviously catatonic presentation of depression could have basically motor disabilities associated with depression as well, right? So acting out with uncontrolled bodily movements as well, catatonia. So in that case, uh, or in severe depression, if nothing is working so far, electroconvulsive therapy, electric shock therapy basically, can be utilized as well, right? Then again, if so many things are not working, it may also not work, right? But it's about trying these things. Right. So, first episode, first remember, we mentioned here that at least trial period should be for 8 weeks. That could be uh, basically for duloxetine. And in general, when a patient started medications and their depression episode has been over, they are in remission, continue treatment for at least 6 months, right? So treatment of depression once started should last for 6 months, right? That's the recommendation. So referral for psychiatric evaluation, in which case when patients are on electroconvulsive therapy, which means if they have severe depression and is not much easily manageable by the treatment methods you've chosen so far, including the last thing, electroconvulsive therapy, or and if you've done that, they could actually be catatonic as well. So in that case, referral for psychiatric evaluation is recommended. And otherwise, patients with mania, psychosis, and as I said, catatonia, right? Treatment. Resistant depression, drugs are not doing anything, not patient is not responding to them, refer for psychiatric evaluation. There may be an underlying other psychiatric condition that is leading on to and presenting to some extent as depression as well. Admit the patients when they have suicidal tendencies in depression, when they have psychotic symptoms as well, they have homicidal tendencies, and otherwise are gravely disabled and then uh, depressed as well, right? So for example, a gravely disabled patient, totally immobile on bed with severe depression, presents to the hospital, otherwise they're fine. I mean, you cannot ideally, ethics, uh, I mean, different hospitals rules and guidelines may be different, but otherwise should be admitted, should not be sent back. Right, and this I've basically included for you to actually get some insight into delirium, that you already know what it is. Inattention, confusion state coexist a lot of the time with dementia, and this is a comparison between dementia and delirium, right? And sleep wake cycles are disrupted in delirium, and in dementia they are not much affected. Alertness is impaired in delirium, whereas dementia is not affected. Dementia is mostly memory problem, isn't it? Speech in delirium, incoherent, rapid or slow. There are linguistic issues, so speech-related problems in delirium when they are confused. Uh, and then in dementia, it's not confusion; it's lack of ability to, recall words, right? And that's what leads on to the language and communication problem. Delirium may also have hallucinations and illusions during the episode of delirium, whereas dementia does not, right? And the behavior during delirium episode can be agitated, withdrawn, or depressed, right? Whereas in dementia, that's not the case, mostly not the case. But we know dementia also coexists with depression a lot of the time, so that depression just may present that way. So, and then course delirium acute, abrupt, and variable. Fluctuations are there. Dementia, it develops slowly and steadily and gets worse, persistent, progressive, insidious, slow and steadily, stealthy, right? But in vascular dementia, stroke and trauma, it can abruptly develop, right? So that is quite obvious. So attention, so I kind of already know what delirium is. Attention deficit and not a memory problem, acute fluctuating disturbance considered associated with change in cognition, possible perceptual disturbances, right? Hypoactive, hyperactive, we mentioned hallucinations and illusions can also be coexisting with delirium. Patient can be hyperactive or hypoactive, so they could be acting out or totally, just not doing anything at all, frequently coexisting with dementia. And the pathophysiology, it could be as a result of, just a minute, right? It could be a consequence, an outcome as a result of underlying medical conditions, infections, coronary ischemia, you know, not enough blood going to the brain, sorry, to the heart, and therefore to the brain. Chances are hypoxemia, metabolic derangements may be responsible for delirium as well, right? And up to 65% of hospitalized elderlies experience delirium, right? And more than 25%, uh, so 75% up to may not after discharge experience delirium, but up to 25% and a little bit more than that may keep on experiencing delirium even after discharge, right? So that's something to look forward to, or otherwise keep in mind. If a patient is experiencing delirium in the hospital, if you remember this, you can advise them and their attendants, relatives as well, that there are some chances that this may keep on happening too. So please be cautious about it and report it if it happens and gets worse. Risk, for example, imagine a patient, a driving patient, and the episode of delirium, confusion, not knowing what's going on, what's happening, what would happen, totally uncertain. So, risk factors for delirium are cognitive impairment, whichever conditions cause that, can cause delirium, severe illnesses, right? Polypharmacy, multiple drug regimens, psychoactive medications, sensory impairment, whatever causes it, like, for example, poor eyesight and altered and, you know, less and or decreased hearing, for example, sensory impairment, depression, right? Alcoholism. These are the things which are at extreme high risk factors for causing delirium. Clinical workup for such patients. Now, then again, we have quite a lot of tools, a variety of different types. This also, I think, I don't have. Or let me see. Dementia rating scale. Yeah, we have this one. So let's look at that. This is dementia rating scale. Right, questions and then answers and scoring for that. Right. So will be shared with you too. This is for dementia. And this is likely confusion assessment method, right? So a short version of it and a long version of it. So um, let's go back here. Variety of short, long, 3-minute ones, right, which take just 3 minutes for assessment. The ones, the confusion workups for intensive care units, because scenarios are different there, or severity of confusion measuring tools. So there's variety of different tools to measure confusion, which is delirium basically. One of them I have for you to look at later on. This one, confusion assessment method, right? And obviously it will be assessing for the acute onset, the fluctuating course, inattention, lack of attention, disorganized thinking, or altered state of consciousness. Now, medication to be assessed means the drugs to pay attention to if the patient is already on them, which have been found to be associated with delirium, specifically in this age group, right? So, what are those? Any new drugs that a patient was recently prescribed could be responsible for causing delirium. So, ask about that if the patient has been recently prescribed, yeah, and then recently means even in past few weeks, okay, discontinued ones, they were on a certain drug and then now for whatever reason, for something else, they have been re-prescribed another drug, maybe it was not effective or whatever, and now delirium. So discontinued drug could be a withdrawal of that one. Dose adjusted, for whatever reason our drugs dose were decreased or increased, right? So if there is that case, note that one too. Sedatives, hypnotics, anticholinergics, opioids, benzodiazepines, H1, H2, and all these obviously um, are there associated with delirium too. So ask about them and note them down as well, right? And for, because we said what things, risk factors, remember for delirium we listed them. So for that, the workup: complete blood count, blood urea nitrogen, serum electrolytes, creatinine, glucose, calcium, albumin, liver function tests, urine analysis, ECG, ABGs, arterial blood gases, serum magnesium, medication levels in the blood. Whichever medicines the patient is taking, their levels can also be checked. Uh, with toxicology scan, blood cultures, chest radiographs, urinary toxin screens, lumbar punctures, right? All of that can be done to see if there are some findings, right? Not necessary to be doing all of it at the same time. As long as you have found something, work on that first and see if delirium improves, then go to next level. And how to decide about that? I mean, it depends on the cost as well, and the health system. So begin with obviously the blood routine work, and then from there onwards go to other one. ECG also quite cheap. These still quite affordable, but not. Chest radiograph, blood culture a bit more expensive, serum electrolytes, CBC, and glucose, blood glucose, calcium, albumin, quite affordable. LFTs, bun, comparatively more expensive. Urinalysis, still quite. So depends, right? When you actually run for these tests yourself, order them, you'll get to have an idea about their costs, and then that's how you'll have to work with your patients. And most of the times in private practices or in our hospitals, we are just not able to. We don't even pay that much attention to delirium. The point is, you're taking care of elderly, right? In a responsible environment. So obviously, then you have to know about it. Right now, delirium in hospital, history. Did they present with a trauma and then they have delirium, right? Or otherwise, they have any new local or focal neurological site? What does that represent? It represents injury to the brain or damage or degeneration of a part of a brain. That's what these two represent. If there's a history of trauma, that could be responsible for delirium. If there is any new focal signs developed recently which were not present, neurological sign that could be responsible for delirium. So CT head may help us evaluate these two things, and that's quite a lot of workup. I mean, if in maybe in Pakistan you were to do all of this, it could cost anything like, depending on the institution, like $300, maybe even a little bit more than that. So that's a lot of money for an elderly, especially, right? And if it's costing $300 in Pakistan, imagine how much would it cost in US. It could cost anything more than, you know, tens of thousands, at least more than, I would say, $10,000, something like that. A lot, right? What's the time? Time is already a few minutes over. Let's just get done with this delirium and then we'll finish the call. So, how to basically, the goal is prevention, and how do we do it? Then again, multifactorial approach is going to be there. First thing, improve cognition, right? And we have already talked about the behavioral approaches to improve cognition, which includes reorientation of the patient. What does that mean? It means, yeah, they are coming in and out of this confused state, so we need to reintroduce them to their surroundings, the people around them, to what is daily routine. So reorienting them, more excursions, more you know orientations. Take them to the shop, take them to a park, take them for a walk, take them to socialize with their other friends, maybe meet family, right? Physical activities, improving socializing with family and friends. And obviously, wherever they live, whichever setting they're on, we need to improve their sleep as well. So to work around that, massages help a lot for elderlies. Noise reduction, minimizing interruptions at night, especially for elderlies, right? Improving and aiding in whichever way, getting devices, hearing aids, glasses, or walkers, as it's called, as for mobility, will help them be more, uh, you know, in reorientation, right? Hydration status to be corrected if that is a problem. And overall, it's been seen that drugs don't help in prevention of delirium, right? So, or even improving the outcomes. So, keeping that in mind, the best approach will still be all of these things that we've talked about. So, management is mostly supportive, reassuring, reorientating, and treatment of underlying causes, which we have already mentioned as well, whatever is required for treating them, and eliminating unnecessary medications, right? Avoiding indwelling catheters and restraints. Now, these confused patients, as we just, they could be depressed, they could be demented, they could be Alzheimer's patients, there could be a lot of variety of patients, isn't it, who are having delirium. So the possibility is that they could be hyperactive as well, and then for that reason, they could actually be, you know, not very reasonable in their verbal and physical activities. So a lot of the time, in care homes or hospitals, restraints, they may be actually tied upon. Their arms and legs could actually be restrained. So avoiding restraints, loosening them up, opening them up, and avoiding indwelling catheters, urinary catheters. I mean, it's not a pleasant thing to have a catheter all the time, urinary catheter all the time, in your bladder through urethra, right? Patients just don't like it. And indwelling ones are the ones which are just left in for at least a week at a time. So it's not a, you know, a, it's not a pleasurable thing. It's not, um, so for socializing as well, it's not pleasant. For people who can walk and move about and have to have an indwelling catheter, actually wear urinary bags on their waist. Imagine that. And if they are not able to move on their own, then usually, if they are on wheelchairs, they're hanging beside their bags. So it's not a very, good thing. And it upsets individuals. Restraints will upset them. So avoid those ones. Psychotics are the only option that we have, but the evidence that we have for antipsychotics, sometimes researchers have proved that they can lead on to improved delirium. Other ones, times researchers have just not proved that they are going to be of any use. So the evidence is inconsistent. For that reason, we can only say that much: use or don't use. Right. So we have haloperidol, the more common one, as you mentioned before. The dosage for that, and quetiapine and benzodiazepines are only going to be considered for patients who were alcoholic and are suffering from delirium then, right? And secondly, if they were already addicted to benzodiazepine and are on withdrawal, so they were discontinued, and likely this could be a trigger of that withdrawal. So for those patients, benzodiazepines may be considered, otherwise not. Other options already mentioned, right? And for patients on ventilators, elderly, right, whatnot, variety of it. So generally for patients on ventilators, we keep them sedated, isn't it? So for that reason, propofol, and along with that, or in addition to propofol, or without propofol, we may actually give dexmedetomidine, right? So to facilitate basically them on uh, ventilators. Uh, these could be added to the antipsychotics. That has to be kept in mind. Right? When to refer? When the initial evaluation is not revealing. Differential diagnosis is something other than delirium as well. And refer the patients to then again neurologist, neuropsychologist, or geropsychiatrists, which means psychiatrists who specialize in dealing with. Okay, 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 okay. Next class time is there. Thank you very much. Then I'll stop here, and see you next time. Didn't know you have another class right now. Take care. Bye bye.